Hello, welcome to the 10-minute CME. Today we shall see how to diagnose cases with COVID-19. I am Dr. Ramasubramanian. I am a consultant infectious diseases at Apollo Hospitals, Chennai. I am also the medical director of Capstone Multispeciality Clinic in Chennai. It is really frustrating when sometimes we know clinically that the patient has COVID-19 and the RT-PCR or the antigen test repeatedly comes negative. There are also times when the person remains asymptomatic and his RT-PCR test repeatedly comes positive. Sometimes the person has COVID with high fever and the CT scan is normal. How do we interpret these situations? How do we know that this person has an acute infection which could spread to others? I hope in the next 10 minutes we shall clarify all your doubts. When do you suspect a person to have COVID-19? The person can have symptoms of fever, respiratory symptoms like coryza, sore throat, cough, and breathlessness. The person may also complain of muscle pains, chills, sometimes conjunctivitis, and loss of taste and smell especially is quite typical of COVID during these times. The patient may also complain of headache, nausea, diarrhea, and may have features of hepatitis. So anybody who comes from a zone which is endemic for COVID-19, where there is community transmission, or has visited this place and presents with these symptoms, one has to think of the possibility of COVID-19. We also need to think of COVID-19 when somebody presents with late complications of COVID, which may be thrombotic, so they may present with myocardial infarctions, ischemia of the bowel due to block in the mesenteric arteries, or sometimes stroke. All these can be symptoms of COVID-19 and we need to consider doing tests to detect this infection. The diagnosis of COVID-19 is based on direct tests, which can be either antigen detection or detection of the viral genetic material through an RT-PCR. It can be indirect tests or antibody tests, and it can also be ancillary tests, which are supplementary, mainly imaging modalities. The antigen tests are generally quite specific, about 95% specific, but the sensitivity is very poor, only in the region of 50 to 60%, which means if you have a patient who tests positive for the antigen test, the diagnosis of COVID-19 is highly likely. But if he tests negative and your clinical suspicion is strong, you may need to do the RT-PCR to confirm the diagnosis. The RT-PCR test is the gold standard. It is done using various samples, which I shall tell you shortly, and the presence of genetic material confirms the person as infected with COVID-19. We also have a TrueNat test widely available in India, which does not require the expense and the necessities of air conditioning required for the PCR studies. The TrueNat test is done using a portable machine, which is light and can be battery powered and can be taken or transported to even villages and other smaller centers which may require diagnosis of COVID-19. The Gene Expert or the CVNAT test is also a useful test, which is very quick with a fast turnaround time. And there are other modalities of detecting the PCR through isothermal amplification, through the CRISPR technology, or the next generation sequencing. The detection of viral RNA by RT-PCR is mainly done through target genes which are present in the SARS coronavirus 2. This may be the nucleocapsid antigen. This may be the open reading frame antigens. It can also be the envelope and the spike protein antigens. There is something called the cycle threshold, which basically refers to the replication cycles which are required to produce fluorescence and detect the RT-PCR or the genetic material. So normally, the higher the viral presence, the lesser the number of cycles or the lesser cycle threshold to detect the virus. So intuitively, people think that if the cycle threshold is low, the person is infectious, and the cycle threshold is high, which means there is a low level of virus, then the person is less infectious. But this is not correct. The cycle threshold is not validated or standardized across the various platforms. Platforms like CRISPR, isothermal, PCR, and even other modalities may not be very reliable. So even though we consider that cycle threshold of less than 40 is to be considered as positive, the actual number may not have much of clinical relevance because of lack of standardization and the lack of correlation between the infectivity or the clinical progression based on the cycle threshold. The timelines of detection is important. In general, the virus or the viral antigen can be detected even 48 to up to 72 hours before the person manifests symptoms of COVID-19 and generally persists for another 6 to 7 days after onset of symptoms. In general, beyond 8 days in mild to moderate infections, it is very unlikely to have viable virus which is detected by culture. Please remember that the presence of genetic material through the RT-PCR platforms does not mean that the person has viable virus. It only tells us that there is genetic material, and sometimes the RT-PCR tests can remain positive for several weeks. This is usually because of dead genetic material being coughed up from the lower respiratory tracts. The RT-PCR test is highly sensitive for samples derived from bronchoalveolar lavage. 93% positivity is seen. When you do a sputum as the media, then you find almost 73% sensitivity is present. For nasopharyngeal swab, the sensitivity is 63%, and for oropharyngeal swab, it can be as low as 32%. This has to be kept in mind when interpreting the RT-PCR results. You can get false negative results sometimes in patients who are clearly positive if there is a problem with the sampling technique, if there is a deficiency in the transportation and storage of the sample. If the false negative results are seen in a person whom we clearly suspect to have COVID-19, then we may need to repeat the test usually after 24 to 48 hours. False positive tests can be seen if there is a contamination of reagent or if there are other technical issues. Sometimes equivocal results can be given if there is, instead of 2 or 3 genes being detected, there is only 1 gene which is detected. The nucleocapsid gene is more sensitive and found in greater abundance. So if only either the nucleocapsid gene or the envelope gene is identified, then the test may be equivocal. So the test may again have to be repeated in 48 hours to see whether it is positive or negative before giving a clear result. A repeat testing is done when you clinically suspect the strong possibility of COVID, but the first test comes negative. But a repeat testing is not indicated to decide if the person is infectious or not. Once the person is infected and it is tested, if the person has mild or moderate infection and recovers in 10 days, we remove isolation. For severe infections, which may mandate the patient to be on mechanical ventilator or high flow oxygen, up to 20 days is the infectious period, and the person is generally removed from infection and need not have a repeat testing done. Antibodies can also be used to detect COVID-19, but they should not be used for acute infections. The antibodies may be used in mild to moderate cases where the person is symptomatic beyond 14 days, or it can also be used as part of seroprevalence studies. IgG and IgM antibodies generally are detectable 4 to 5 days after onset of symptoms. The IgM antibody peaks in about 5 weeks and can decline and disappear after 7 to 8 weeks. The IgG antibodies may be present for several weeks or even months. In general, the specificity of antibody tests is high if the antibodies are against the nucleocapsid antigen, but the antibodies against the receptor binding domain of the spike protein are believed to be more specific and neutralizing in their ability as far as protection is concerned. Point of care testing with antibodies has been used, but they are less sensitive, especially the commercially available tests are not very dependable. Imaging studies are supplementary to the diagnosis of COVID. The CORADS score basically refers to the COVID radiology and data systems representation, where suspicion for coronavirus or COVID-19 is based on the changes which are seen on the CT scans. Subsequently, if the person is confirmed to have COVID-19, the CT severity index is used to determine how severe the infection is. The characteristic abnormalities on the CT scanning will include peripheral ground glass infiltrates, ill-defined margins, air bronchograms, either smooth or intermittent interlobular septal thickening, and also thickening of the adjacent pleura. These are all non-specific, and this can be used only as supplementary tests, and they are not diagnostic, even though 85% of people with COVID-19 have these changes. There are several biomarkers which can be used, which include the C-reactive protein, the procalcitonin, D-dimers, the LDH, ferritin, and interleukin-6. These are all useful in prognostication and monitoring the patient, not in the diagnosis of COVID-19. So the take-home messages will include direct tests are specific for the diagnosis of COVID-19, which means you need to detect the genetic material to confirm the diagnosis. Clinical application of cycle threshold values is uncertain. Viral genetic elements may persist for several weeks after infection, and a routine repeat testing is not advised to determine infectivity or if the infection is cleared. Antibody tests are useful for late diagnosis or serosurveillance only. Imaging studies are non-specific, even though they may be more sensitive at times. And please do not use CT scans for asymptomatic patients to diagnose COVID-19. Thank you.